Thank you, and it's my pleasure to talk about the management of BCG unresponsive cystectomy ineligible bladder cancer patients and the role of immune therapy, particularly pembrolizumab and other checkpoint inhibitors in this disease. As we know, we have basically two types of bladder cancer, that which is non-muscle invasive and that which is muscle invasive. The non-muscle invasives include the TIS, TAs, and T1s. And the muscle invasives, of course, are much more potential, have higher potential in terms of spread to other areas. This is a very common problem, as about 75 to 80% of bladder cancer is non-muscle invasive. It's expensive, and with checkpoints, I think it's even going to become more of an expensive treatment or tumor to treat due to long-term management. We have a low rate of recurrence, and a lower rate of progression. The low-grade tumors rarely progress, but the high-grade tumors can progress on to muscle invasion and can cause death because of dissemination of disease. We know that intravesical therapy can reduce the recurrence and progression of non-muscle invasive bladder cancer. And then the standard of care for those patients who do not respond to BCG is radical cystectomy. And of course, that has an important impact on the patient's quality and quantity of life. So BCG, as we know, is used for non-muscle invasive disease as part of initial management. We resect all tumor. If it's high grade, we give them intravesical BCG. If it's low grade, we usually follow them with cystoscopy only. This can reduce recurrence of bladder cancer, progression, and death. It must be given for at least a year and sometimes up to 3. And in general, we found this is superior to mitomycin C chemotherapy. There are, in the past, FDA-approved agents, and this is still approved, valrubicin, but the treatment really was never really used. And there are others who do use combinations of gemcitabine with docetaxel, and there are other investigational treatments that are currently under investigation. But once a patient fails BCG, cystectomy is the best salvage option. BCG was FDA approved in 1990. And the mechanism is complex. It's a multiple pathway form of immune therapy. It's internalized by the urothelial cancer cells as well as the immune cells, and a release of cytokine occurs as well as chemokines, and these will help to present and activate T antigens. It's safe. Less than 5% of patients will develop complications, and these include fever, hematuria, as well as granulomatous prostatitis. So we know that BCG acts by attaching to the urothelial cells through fibronectin and the integrins. It's internalized into bladder cancer cells, and this is through a process of phagocytosis. These antigens are then presented, and there are immune recruitment of CD4 and CD8 cells, as well as NK cells, and then release of cytokines, which will cause further inflammatory and immune responses, as well as the attraction of NK cells as well as macrophages. There are multiple definitions of BCG failure. These include those who relapse after achieving a disease-free survival of 6 months. They're intolerant patients who have a less than adequate course of therapy. There are refractory patients who fail to achieve a disease-free survival 6 months after the initial BCG, or fail to achieve it disease-free survival at 3 months after the initial BCG therapy. And then there are resistant patients whose disease improves, then resolves, but is evident again at 3 months after the initial treatment. So guidelines for BCG relapse and salvage regimens with intermediate or high-risk patients with persistent TRCS after course of BCG or second induction course. If a patient is unfit for surgery, don't describe additional BCG also to a patient who has documented intolerance to it or recurrence of a high-grade lesion. We also look at those patients who don't respond to the initial intravesical BCG if they've not received adequate treatment, and again, if they've got persistent disease. Intravesical chemotherapies are also used for BCG failures, but again, for the combinations of docetaxel with gemcitabine, doxorubicin, epirubicin, these are not approved by the FDA, and only valrubicin is approved. So I'd like to talk about the mechanism of checkpoint inhibitors. These are cell or monoclonal antibodies that interfere with the interaction between the tumor cell and the immune cells. Cancer cells are mutation machines, and they can make mutated proteins that appear foreign to the immune system. T cells normally can recognize and attack and kill these foreign cancer cells. And the more antigens that are present, usually more present with mutated, high degrees of mutation, excuse me. And if we take the brakes off the immune system, we have a natural system that regulates the immune system. It's the PD-1, PD-L1 pathway. Cancer cells exploit this, and they evade immune attack by expressing PD-L1. It's almost like the cloaking device in Star Trek, where the cancer cells can cloak themselves and the immune systems don't see it. By interfering with this particular pathway, we can actually interfere with the interaction between the tumor cell and the immune cell and reactivate the immune system so it now recognizes that particular cancer cell. And this plays an important role. And we know that drugs such as Pembrolizumab and atezolizumab and other checkpoint inhibitors are FDA approved for second-line treatment in patients with metastatic disease. So the Keynote 57 trial was a single-armed, open-label phase 2 study that evaluated pembrolizumab given at 200 milligrams every 3 weeks in patients with non-muscle invasive disease who had failed BCG. What I'm going to show here is the results from cohort A, which was 130 patients with carcinoma in situ with or without papillary disease. This could be either high-grade TA or T1. Patients were evaluated with cystoscopies, and the primary endpoint was complete response. There was the absence of non-muscle invasive disease in cohort A and disease-free survival in cohort B. Treatment was supposed to continue for 24 months in the absence of progression of disease. So these are the baseline characteristics of the 103 patients entered on the study. As we see here, they're predominantly white, good ECOG performance status. Number of median prior BCG installations was 12. All of these patients had urothelial transitional cell carcinoma histology, and about 12% had carcinoma in situ with T1, 15% had carcinoma in situ with high-grade TA, and 71% had carcinoma in situ alone. PD-L1 positivity was seen in about a third of patients, and overall, about 60% had low levels of PD-L1 staining. So this is the response data at 3 months. The overall response rate was 40%. About 45% of patients had some persistence of disease. And if we look at progression to T2 disease, which I think is extremely important, no patient progressed on to T2 disease. Side effects seen were those that were seen with typical checkpoint inhibition therapy and predominantly rash, and fatigue, liver function abnormalities. There was one death on study, but this was from an unrelated cause. SWOG has looked at atezolizumab in patients who are BCG unresponsive, and they received 1 year of atezolizumab every 3 weeks for 17 cycles. The primary endpoint was pathological complete response rate at 6 months in the carcinoma in situ patients, and this was determined by mandatory biopsy. The trial was opened in February 2017, very similar patient characteristics. Carcinoma in situ only in 58%, TSTA in 19%, and TST1 in 18%. So if we look at the primary endpoint, complete response at 6 months, 27% of patients achieved this. By the pre-specified plan, the trial did not meet its primary endpoint. If we start looking at unplanned secondary endpoint, the CR and CIS patients at 3 months, 42%, which is comparable to what we saw with the pembrolizumab data. But again, that was not the primary endpoint of the study. So there does seem to be some activity. Whether this will move forward is not clear. So the question is whether there are other trials that are looking at immune checkpoint inhibition therapy in this state of disease. The answer is yes. We talked about the Pembro trial and the atezolizumab trial. Durvalumab is being evaluated in the situation as well as other combinations of atezolizumab and immune therapy, as well as durvalumab is combined with BCG. So in conclusion, immune checkpoint therapy with pembrolizumab can lead to complete responses in 40% of patients. A similar response rate was seen in the SWOG atezolizumab trial at 6 months, but that was not the pre-specified endpoint. Current trials are underway to evaluate other checkpoint inhibitors and schedules in this disease. Thank you for your attention.